Georgilopoulos. I'm a sports physiotherapist on the Gold Coast in Carrara. As with most practitioners, I treat a lot of low back issues. About 80% of my patients will have back pain at some stage or other, and I'm often asked the same sorts of questions about low back pain. So I thought this would be an opportune time to try to explain some of the most common features of low back pain. What I'm holding here is, of course, a model of a human spine. This is facing forwards, this is facing backwards. The features that we need to look at are predominantly the vertebral bodies, or the vertebra. They're made of bone. In between each of the vertebra we have a disc which is made up of a very soft structure which has a nuclear centre. That structure changes shape as we bend forward, bend backwards and change direction. The idea of having a disc between each of these vertebral bodies is that we don't allow compression to exist between the bones, which stimulates or enhances early degenerative changes. The nerves are displayed here in the yellow. There is a spinal cord that runs through the middle of the vertebral bodies of the spine, and of course at the very base here we're representing a disc prolapse, and a disc prolapse is probably one of the most common features that we see with low back issues. Predominantly there are two types of low back pain predominantly that people present with. One is disc related low back pain, and the other one is facet joint. I'll go about trying to explain those two very, very briefly. Predominantly we're looking at the two vertebral bodies, above and below, with the disc in between. As we said previously, the spinal cord sits well protected within the back part of the spine, or the vertebral column, and the nerves come from each side. The features that I'd like you to be able to see is that we also have a facet joint at the back. These facet joints stack one above the other and provide support for the lower back, so that we can stack each of these vertebral bodies one above the other and give ourselves some support. When bending forward, this is where most people end up having a problem with their disc. When bending forward, what tends to happen is that we compress the anterior part, or the front part of the disc, and the nuclear material within the disc gets squeezed towards the back. The onus is then on the posterior aspect of our disc to be able to withstand that amount of force. If it's not able to through previous injury, or through prolonged sitting or bending forward where that ligament or part of the capsular outer wall has been stretched, then we can end up with a prolapse disc. Ordinarily this is what it looks like. We come forward and you get a particular amount of pressure being applied at the front, and any directional change is easily able to be accommodated by this particular disc. When it's damaged, however, if we turn this over, if there's a deficiency at the back part of the disc here, by bending forward there's nothing holding that disc where it needs to be, and so coming forward squeezes the inner contents of the disc and it bulges out. How much it bulges out, or how far it bulges out, will depend on what sort of symptoms you get. Of course, the greater the amount of force, the further the pressure on the nerve, and consequently you can end up with what we call referred pain, which radiates down your leg and can go down to the level of the calf or the foot. The symptoms you can end up with are obviously pain, numbness, pins and needles, or a burning sensation. Any one of those symptoms can exist on their own, or they can exist as a combined part of your low back issue. The aim of having a disc like this, the aim of treatment, of course, is to try to reduce that disc prolapse. So people who suffer from disc prolapses characteristically describe their pain as emanating from a bending forward or a lifting type of injury. You've either lifted something very heavy, or you've bent forward and twisted, and in doing so you've created a bulge or a prolapse, or a slip disc is another term for it, and that amount of prolapse will determine what sort of symptoms you get. Typically, people with this sort of a problem will have difficulty sitting or bending forward. Coughing and sneezing may be a problem. Any sort of exerted activity is going to cause some issues in the lower back. The aim of treatment predominantly has to be to reduce that prolapse, and to do so we can do things mechanically by arching backwards, So if bending forward makes it worse, typically arching backwards should help to relieve it. We call these McKenzie type exercises, and there's a series of exercises we can do into a backward arching position that can assist in the reduction of the disc prolapse. We can also lie on our back where there's a disc prolapse like so, and by rotating in the opposite direction we can tighten up the remnants of the annulus or the outer wall of the disc there, and in doing so that helps to also reduce the disc prolapse as well. The aim of our treatment is to allow some healing to occur at that point, and we need an inflammatory response for that to happen. Failing to get a meaningful amount of scar tissue at that point will not enable our long-term repair to exist. In other words, if we don't get a proper healing initially, we can end up with recurrent issues, and many people do suffer from recurrent back pain, and this is possibly one of the main reasons why they do so. The other type of back pain that most people will present with is facet joint or facetogenic back pain, and that's pain emanating from issues to do with these facet joints at the back. Now, these are weight-bearing structures, just like your knee and your hip are. So the more impact loading we have, the greater the force through these joints. Typically, this sort of pain is different to disc-related back pain. Whereas disc-related back pain is painful when you're bending forward and sitting, facet or facetogenic back pain is generally worse when you're arching backwards, and the reason is because if there is an inflammatory response at that point, coming back into a position where the joints are compressed will aggravate those symptoms. This is a sort of pain that often we complain about when we've been shopping for a while carrying some bags, or if you're a runner and you're running for a long period of time. The impact loading of running can lead up from your limbs, of course, up into your lower back and compress these joints, and the treatment for this is generally the opposite to what we normally do for disc-related back pain. With disc pain, of course, arching backwards relieves the disc prolapse. With facet joint pain, bending forwards and mobilisation often releases that joint pain. I'd like now to speak about spondylolisthesis and pars fractures. This is a very uncommon problem, but it can occur in sportsmen, in particular cricket fast bowlers, soccer players who take corner kicks repeatedly, or any other athlete who rotates through his spine. The reason we have a problem is that we can end up with rotation through the spine, putting pressure on the back part here of the spine. This bridge here is called the pars interarticularis. And if there's repeated force through here, through rotation of the spine, what tends to happen is that we get a stress fracture through here, and that stress fracture can develop into a fracture, and if we end up with a fracture through here, the amount of torsional or rotational force that's applied through the spine can cause an equal and opposite fracture through the other side. If both those areas end up with a fracture, we move that section away and you end up with an unstable lumbar section. And here it is demonstrated here. So we have a fracture at this point, which is the pars interarticularis, that's the name of that particular bridge, and the opposite part here also has a fracture as well, so that essentially if both of those are fractured, you can end up with separation of the two parts of the vertebral body. What that means is that essentially that whole section of vertebral body can slide forward, and that slipping forward is called a spondylolisthesis. The problem with that, of course, is number one, it's going to be painful mechanically at that point. Number two, it's quite likely to drag with it the disc that's attached between that section above and the section below, and so those two discs are then subject to increasing amount of force and probably distortion, and ultimately can be damaged quite severely. This is a little bit more complex of an issue to try to treat. Fundamentally, any position where we're arching backwards is likely to exacerbate the problem, so we certainly don't want to be doing that. Unlike the disc-related problems previously that we spoke about, where arching backwards is a useful technique, arching backwards with the spondylolisthesis is likely to exacerbate the problem. So we certainly don't want to do that. Ultimately, we will reduce the symptoms through a specific type of manual techniques, and we need to strengthen the core, because ultimately if the abdominal muscles here at the front compress quite firmly and support the anterior displacement of that vertebral body, we'll be able to hold things quite tightly in here, and that will help to settle down the symptoms. And there are a lot of elite athletes who are competing with just such a problem. It can have an effect, of course, on hamstring flexibility, as the slippage or the spondylolisthesis can affect the sciatic nerve or components of the sciatic nerve. This is represented here. And as you get anterior displacement of the vertebral body, you can put pressure on that nerve and cause some hamstring pain or tightness, and eventually some issues in the hamstrings can be a recurrent nature for some athletes. But for those that do suffer this particular problem, there are many options, and surgery is not necessarily one of those. Very, very few people statistically end up with surgery with these sorts of problems.